5 facts about co-occurring disorders for professionals partnering with families affected by substance use. Number 1. Co-occurring disorders, or COD, are complex, bidirectional, and often fluctuate over time. According to the National Institute on Drug Abuse, there are 3 pathways to comorbidity for substance use and mental health disorders. Number 1. Common risk factors, including genetic factors, trauma, and adverse childhood experiences, can contribute to both SUDs and mental health disorders. Number 2. Mental health challenges and disorders can contribute to substance use and SUDs. Number 3. Substance use and SUDs can contribute to the development of mental health disorders. Regardless of the timing, severity, and development of each disorder, co-occurring mental health and substance use disorders should be assumed to affect and possibly exacerbate one another. CODs must be treated simultaneously. Parents with a co-occurring mental health disorder may struggle to manage the day-to-day responsibilities of parenting, such as recognizing and responding to children's physical or emotional needs, setting and holding safe and appropriate boundaries for their children, and regulating their own emotions, such as irritability, anger, or overwhelm, around their children. Number 2. Co-occurring disorders are prevalent but undertreated. Approximately 20% of adults with a mental health disorder also have an SUD, and approximately 40% of adults with an SUD also have a mental health disorder. Adults with SUD are 3 to 6 times more likely than those without the disorder to experience depression, anxiety, ADHD, post-traumatic stress, and bipolar disorders, and 4 to 8 times more likely to experience antisocial or borderline personality disorders. Adults with opioid use disorder and polysubstance use are at even higher risk for experiencing a co-occurring mental health disorder. People with COD typically show lower treatment adherence and higher rates of leaving treatment prior to completion, and those in a treatment court are more likely to drop out. Parents with a COD and involved in the child welfare system experience lower rates of reunification than those without a COD. Although extremely prevalent, more than 90% of adults with COD don't receive services for both conditions. In 2018, 50% of adults with COD received no treatment at all. 41% received mental health services only. Less than 3% received SUD treatment only. Just 7% received both. Parents with COD are unlikely to receive family-centered care related to either their substance use or mental health disorder, although a family-centered approach is shown to improve treatment outcomes. Number 3. Accurate diagnosis and treatment of COD is contingent on effective, integrated, and ongoing screening and assessment practices. Disentangling signs and symptoms of substance use and mental health disorders to provide an accurate diagnosis and appropriate treatment is challenging. To have the most success, clinicians should screen, identify, and evaluate each disorder concurrently. Use a comprehensive assessment process that includes a review of the client's chronological history of past substance use and mental health symptoms. Reassess clients for a co-occurring mental health disorder if they exhibit symptoms that are persistent, severe, and resistant to SUD treatment. Observe clients after a period of abstinence to distinguish between the effects of substances or withdrawal and symptoms of a co-occurring mental health disorder. The DSM-5 specifies that individuals should be abstinent from substances for 4 weeks before an accurate mental health diagnosis can be made. And lastly, rescreen and reassess clients repeatedly over time to monitor any new or changing symptoms as they progress in treatment. Number 4. Integrated treatment improves outcomes for people with COD. The treatment field has used various models for treating COD, including single, based on the belief that once the primary disorder was treated, the secondary disorder would resolve itself. Sequential, acknowledges the presence of a co-occurring disorder, but treats one at a time. Parallel, substance use and mental health disorders are treated simultaneously, but by separate clinicians, often at separate facilities. And integrated, addresses all clients' diagnoses and symptoms within one agency and by a single team of collaborative providers that actively combine interventions to treat the whole person more effectively. Single and sequential models have historically been used, but are now known to lead to worse outcomes for some clients. Parallel models, while an improvement over the previous models, do not provide the comprehensive and collaborative care that clients need. Integrated treatment produces the best outcomes. Integrated treatment exists on a continuum based on treatment programs' capacity to serve people with COD. Elements to consider when looking for integrated treatment include integrated models of assessment, intervention, and recovery, collaboration between clinical providers, co-location of services, shared treatment plans and records, case review meetings, and cross-training, ongoing assessment of co-occurring disorders with goals sequenced by critical needs, relapse prevention planning focused on identifying cues, warning signs, and coping skills for co-occurring disorders, and connection with outside organizations, providing supportive services for those with COD. Number 5. A family treatment court can enhance its resources and strategies to improve outcomes for parents with COD. Teams can access the following resources: psychiatric consultation and medication management, crisis response services, psychoeducation about mental health for participants, cross-training about COD for all team members, peer support specific to those with COD, COD mutual support groups. Teams can also employ these strategies when working with parents. Recognize that a parent's motivational state is specific to each disorder. Assist parents with cognitive limitations and difficulty concentrating using repetition with core concepts and expectations. Avoid abstract discussion. Keep interactions brief. Present information in multiple formats, and use role play to practice strategies. Provide support and teach skills in household management, such as scheduling, maintenance, laundry, and meal planning. Support habits associated with stable mood, like healthy sleep habits, regular meals and hydration, movement, supportive community, and a consistent daily routine. Help parents create a consistent and predictable family environment for their children. Integrate mental health needs into discharge planning, such as peer support, parenting support, medication management, and ongoing services if needed. Help parents structure their time, including opportunities for rest, support, and enjoyment. Support parents to educate their children about mental health by giving accurate, age-appropriate information, discussing misconceptions and fears, and modeling language about emotions. If needed, assist parents to locate quality social-emotional support or mental health services for their children. Explore resources available in the community that support parents with COD. And lastly, incorporate mental health screenings into FTC phases to provide timely and appropriate assessments. Thank you for watching. Training and technical assistance is available at any time. You can reach us at FTC@cffutures.org. See you next time.